couple of announcements. Just to follow up something that Kelly said, for the nurses, when you go in the room, please make sure we have the same case diagnosis, and make sure our times mesh. Time in the room is very important. If they don't mix, we're going to have to look at the charts again. Also, when you do it, make sure you have the ASA and the type of anesthesia. It'll either be general, spinal, regional, or MAC. And those have to sync, and just check with us when you go in, make sure that we have the same notation on our computers. Also, word from Dr. Lunge is that we've been doing a good job of working together. If you have any issues with anesthesia, with an anesthesiologist, please bring it to the attention of Dr. Lunge, see if we can tamp it down right there without going outside, because when other people are involved initially, it really can cause problems. We want things to work very smoothly here. They've been working very smoothly. Let's please keep the lines of communication open. First thing you do is talk to the anesthesiologist if you're having any issues with him. We don't have any, or her. We have as you know, we have one woman CRNA. Start there and then go to Dr. Lunge. He's very, very aware and wants things to go as smoothly as possible. Next thing, please remember, on the induction and the awakening of anesthesia, very important times. Sometimes we have idle conversation in the room. It's kind of like flying an airplane. You know, the takeoff and the landing are the times when we really need to focus our attention, when things can go bad very quickly, especially at the end of the case. Please help the anesthesiologist keep things in the room quiet until a patient is awake and on the way to the PACU. Patient confidentiality, also an issue. Remember, it's very important to maintain that. And if people have a good attitude, I think it's getting better. We all work together to have very good outcomes. All right, anybody have any questions on that? Excuse me, excuse me, excuse me. All right, let's start with our entertainment portion of the lecture here.
Are you going to jump up?
All right, this is going to be an interactive kind of thing. Now, does anybody know why I'm playing this song? First of all, who's the artist here? Anybody know the artist? Bueller? Bueller, anybody Bueller? The artist is Joe Walsh. Joe Walsh is a very interesting artist. What's the name of the song? Listen.
Out in the open?
Over and over, right. And you guys are really on today. Okay. And why am I playing the song Over and Over by Joe Walsh? Because we're having a lecture on malignant hyperthermia today, and we need to practice it over and over again, because we don't see it very often, and if we don't see, we don't think about it. If we don't think about it, a patient may die. So, remember the song, remember Joe Walsh. While we're going through this lecture, we're going to talk about Joe Walsh a little bit. Very interesting character. So let's get started. What is malignant hyperthermia? Can anybody tell me what malignant hyperthermia is? Bueller, go ahead.
It's a hypermuscular metabolic state.
Absolutely. It's a disease of metabolism. It's a disease where things go wrong with the utilization of energy in the muscle cells. All right? It's a disease caused by what? What causes malignant hyperthermia? Anybody? No, you answered. You're good. We're going to have somebody else answer. In the peanut gallery over there. What causes malignant hyperthermia? Right. Succinylcholine. What else? No. What's another causative agent of malignant hyperthermia? Anybody over here? Halothane. Give me another causative agent of malignant hyperthermia. Right, isoflurane. Keep going. What's another causative agent of malignant hyperthermia?
Any inhalation agent.
Any inhalational agent. Now, where do we find inhalational agents? On our anesthesia machine. So, the causes of malignant hyperthermia are what? Agents. And who gives these agents? Anesthesia. It's a disease of anesthesia. Okay, that's why we're talking about it. Many physicians have never heard of malignant hyperthermia. Why not? They don't give anything that causes malignant hyperthermia. We do. We're in the operating room. We're the culprits. So we do good things for the patient, and we can potentially do things to harm the patient. So we know that malignant hernia is a disease of metabolism. It's caused by triggering agents, which are all the things we talked about. Succinylcholine is a drug we push to cause paralysis for the induction of anesthesia. All those inhalational agents, those are the ones in the vaporizers we turn on at the start of anesthesia to keep the patient asleep. That's where the fun begins. That's where the havoc begins. So the first thing we need to know is a disease of anesthesia. It's a disease that we can all see in the operating room, and it's a disease that we need to recognize early so we can do something about it. Funny thing about it, between 1915 and 1925, there was a family that had 3 recorded deaths due to anesthesia. They didn't know why. A few years later, one of the doctors reported that a patient got muscle spasm, pallor, and died under anesthesia. And in 1960, a very smart anesthesiologist named Denborough had a patient, a 25-year-old who was going for a setting of a fracture. He was petrified to get anesthesia. Why? 10 members of his family had died from anesthesia. 10. This is 1960 now. This is kind of recent history. Doctor put him under, and he finally got muscle spasms, funny rhythms, and he turned off the inhalational agents, saved that patient's life. A few years later, one of the doctors was doing experiments with a new drug called dantrolene. It's a muscle relaxer, and he found something interesting. Farmers, pig farmers, found that some of their pigs who got very excited before they went to the slaughter, their meat was very spoiled, and muscles were spasming. And this guy found out that this drug dantrolene, if given to these pigs and humans, would stop this from happening. And that's how the modern era of treatment of malignant hyperthermia got started, okay? So it's a disease of what? Metabolism. Now, in order to figure out what happens in the malignant hyperthermia, let's talk a little bit about physiology. You all know about the neuromuscular junction, right? No. Think about what happens when you move a muscle. Your brain gives a signal, it goes down the nerve, and at the neuromuscular junction, we're talking very small size now, acetylcholine is released at the motor end plate. That signal travels down until it gets to the outside of the muscle cell, where it causes a change in a receptor in what, Eric, in what structure? The sarcoplasmic reticulum. These are like bladders outside the cell membrane. And when the signal reaches it, it's called excitation, contraction coupling. It causes a change in a receptor there, and it releases calcium inside the muscle cell. Now what does that calcium do? It binds a protein called tropomyosin. You don't have to remember this for the test, but by the way, guys, you're all listening, right? Because there's going to be a test at the end, and anybody who doesn't pass the test is going to take my spot next time and give the lecture. So you got to listen carefully. So at the sarcoplasmic reticulum, it releases calcium, and it causes a change so that actin myosin filaments can do this. Remember this? And that causes muscle contraction. Requires energy. Now, what happens at the end of this? Do the muscles want to stay like this? No! They want to contract, and they want to relax. Relaxation happens when the calcium comes out of the cytoplasm and back into the, what, Eric? Sarcoplasmic reticulum. Big words, it's a bladder. It's filled up with calcium. So the process requires this and this. All right, so now you got a little, you understand a little bit how this works, and it requires energy. What happens in malignant hyperthermia? Certain susceptible individuals, when exposed to what agents? Give me an agent. Something, what else? Any inhalation, anything you go like this. on the vaporizer. Any of those agents, they are all halogenated ethers. People ask, do we still give ether? All the time. Halogen. Halogen, remember the periodic table, the seventh row over, you got chloride, fluoride, iodide. We don't have any iodide there. But the seventh row of the periodic table has those elements, and different conformations of those give us those agents, and they have specific properties on the individual. What happens when we give to susceptible individuals? Okay, let's talk about it. You guys remember your genetics? It's an autosomal dominant trait, is malignant hyperthermia. Between 1 in 5,000 and 1 in 100,000 people have this trait. You know, when they make babies, you know, you got a gamete, and the father donates half of the genes, and the mother donates the other half. You got the mitosis and meiosis. Well, if on every chromosome there are 2 alleles, each parent donates 1. So if either the mother or the father has the trait for this, we'll talk about more, and the other one doesn't, and they get together, that's all it takes to have the trait. So it's more common than you think. So what happens is that in susceptible individuals, they make a protein that changes a little bit. Remember we talked about calcium to get released from the sarcoplasmic reticulum into the cell. It has to have a receptor that opens up. Well, with the alteration of the genetics in these patients, there's a change in that receptor. It's a protein. It changes the receptor so that when interacted with what? Succinylcholine or any inhalational agent, there might be a question on this, guys, all right? Succinylcholine or inhalational agent, that receptor will open up, and it'll stay open. So what happens if the receptor stays open, Eric? All the calcium floods into the cell, and it overwhelms the cell's capacity to get it back out. So what happens is the muscles can contract. It increases the energy utilization. You get heat. Because it uses aerobic metabolism, you make more of the end products of metabolism, which is carbon dioxide. As the carbon dioxide increases, it causes an acidemia in the body, which causes badness, right? Badness, too much carbon dioxide, too much acid. What organs can affect? Initially, what it affects is the pumper, the heart. So you look on an EKG machine, you can start seeing arrhythmias. All right, so we get carbon dioxide, we get arrhythmias. Now what happens? As it progresses, the cell loses its capacity to keep going because it's used up all the ATP from oxidative metabolism, and now it has to go into anaerobic metabolism to try to maintain cell integrity. Well, after a little while, the cell wears out, it's run out of energy, and the cell begins to die. What happens when the cells begin to die? The membrane lyses, and all this badness gets out into the circulation. What kind of badness? Myoglobin, that's the protein of muscle cells, and enzymes go up because the cell is crying for help. All right? So now we have increased carbon dioxide, we got heat generated, we've got structures coming out, myoglobin, which can get in the body, filtered in the kidney and out in the urine. So now we know a little bit about what happens when a susceptible individual is exposed to any of those agents. All right, let's see where we're at. Does anybody have any questions? I covered a lot of stuff real quickly here.
So is it all depolarizing agents or just what you have?
Only succinylcholine. All right, we have a wonderful drug that I talked about that was discovered called dantrolene. Dantrolene comes in 2 forms. The old form, which is lyophilized dantrolene, which is a mixture you have to mix with water, and we have a new version of also dantrolene called Ryanodex. What's the difference? Well, dantrolene takes a lot of effort to solubilize, and you're all going to have a chance to try this. And it takes time. This Ryanodex is power controlled. It's concentrated, and it's easy to draw up and solubilize. So that's been a big change in the last few years. We're going to run on this, but you're all gonna have a chance to do something about that and see how easy it is to draw this up. All right, so what are the signs of malignant hyperthermia? The first thing is, you see what? What's the first thing you're gonna see? The first thing is carbon dioxide. On all of our anesthesia machines now, one of our monitoring agents is end-tidal carbon dioxide. That's the amount of CO2 we breathe out with every breath. Not only do we have a number for that, we have a waveform for that. And anytime you're interested, come to the head of the bed and we will show you that. All right. Guitar Magazine rated Joe Walsh one of the top guitarists of all time. Isn't that unbelievable? All right, on what song did Joe Walsh get credited with having the best guitar solo ever? Dave?
That's been good.
No, he was playing with the Eagles. What song was one of their most popular songs the Eagles ever put out? Listen to the guitar solo. He splits it up with someone else, and it is freaking.
Yeah, but Don Felder beat him.
Don Felder also did a solo on that song, and they credit both Don Henley and Don Felder with the best guitar solo. So that's a tip for the day. When you go home tonight, I want you to listen to some Joe Walsh. He's got a number of albums out. Okay, let's get back. How many times?
Do we smoke weed like him too?
What's that?
Do we smoke weed like him?
Just
too?
like him, but make sure you're not coming to the hospital next day because we're going to check you. How many times has Joe Walsh been married? Come on. Bueller, over there. How many times? More. How many times do you think he's been married? 5. He's been married 5 times, okay? Good. All right, so you're not, so anybody got any question about the metabolism? It's a disease of metabolism. We know how excitation, contraction, coupling works, and now we have a better idea of what happens in a susceptible individual exposed to these agents. Okay? Good. Anybody questions? All right. We're going to have a little scenario here. Incidentally, somebody asked, well, if someone's susceptible, how often does it happen? Somebody can be a susceptible individual and go through 5 or even 10 anesthetics and not have a problem. And then on the 11th time, whammo, they get nailed. Why does this happen? We don't know. So we know a lot, there's a lot we don't know.
Dr. Adele, how close is the family ties? Because like we'll get, patients when we're doing pre-op interviews and they'll say, my mother had a history of malignant hyperthermia, or my aunt did, or like how seriously are you taking those patients with it?
How seriously do you think we should take that?
I guess
Extremely seriously. Anybody with a family history goes ding, 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 ding. All right? So let me ask you this. So today we supposedly had a patient upstairs. They said, family history of malignant hyperthermia. And the question to me was, what are we going to do about it? Can we do the case upstairs? What's the answer?
Yes.
Yes, absolutely. And we're going to get something else. Why is that? If we know, what are we not going to give? Or, beautiful. And how do we deal with that? Clean machine. What did we used to do in a clean machine? Change the soda lime. Very good question. Does everybody know what soda lime does? No. All right, I'm going to tell you. Bueller, is there a Bueller back there who can tell me what soda lime does? No. Soda lime, what's that?
Can I tell you?
Go ahead.
It filters out the carbon dioxide.
Absolutely right. There's a canister by the anesthesia machine. And by the way, come and talk to us. Most of us anesthesiologists are relatively approachable sometimes, if we're not having a bad day. Okay. Come to us at the head of the anesthesia machine, and we will show you. We like to show stuff. There's a canister, and it's got white particles in it. We have a circle system that delivers anesthesia. So there's an intake that goes into the patient, right through the endotracheal tube. And then there's the out. When the expired gas comes out, it gets filtered through the soda lime, and through 2 reactions, it purges all the CO2 out. So the next breath is hopefully carbon dioxide free. Okay, but the next breath still has inhalational agents, and they can get trapped in that soda line. So the first thing we do when we know or suspect a patient has it is if we had known in advance, we have a clean machine. It used to be that we would run 10 liters of oxygen through a circuit. We'd get rid of our vaporizer, right? First thing, why? Badness for malignant hyperthermia. Get rid of them or tape them up, and we get rid of any succinylcholine in the room, and we run it for 30 minutes, 10-liter flow, and change the soda line. Does that make sense? We don't want any traces of inhalational agents in it. Nowadays, Jim told me, we got something new. The orange things, called vapor cleaning. And you don't have to know exactly how they work. We gotta know how they work. We plug them into the circuit and run oxygen for like 30 seconds and we're good. So that's been a recent advance. So to answer your question, anybody with a family history or a questionable family history, we're gonna do a clean machine and avoid those agents. So you're gonna ask, well, you can't give succinylcholine. You can't give an inhalational agent. How are we gonna give a general anesthetic? Anybody know? We just don't use those agents. So what do we use instead? If we're going to intubate a patient, we have non-depolarizing muscle blockers. Remember, succinylcholine is a depolarizing blocker. A lot of us don't even use succinylcholine anymore. A lot of us use the rocuronium. Well, let's get some rock, let's give some Zemurine. Is that a triggering agent? No! And instead of running the inhalational agents, we can run a propofol intravenous anesthetic. Propofol, perfectly fine. So, if somebody asks now, can we do the case upstairs? Can we do the case down at MRI? We can do the case anywhere. If we know, we avoid those agents, and we have something called a card, malignant hyperthermia card. So, what are your questions?
What about nitrous?
Nitrous is fine. The only agents, simple, succinylcholine, inhalational agents. All right, so let's
What
do.
if somebody's allergic to propofol?
If you're allergic to propofol, then there are very few people allergic to propofol.
Right, but it does happen.
They have something called neuroleptic anesthesia from the old days. You get fentanyl and droperidol. But that's a whole nother issue. And what we would do, if someone's truly allergic to propofol, you gotta find out what it is, the propofol they're allergic to. And it's probably not a propofol allergy. If it is, you try to do a spinal or a regional anesthesia if possible. But that's a very good question. If they're allergic to propofol and they have malignant hyperthermia, you gotta scratch your head and say, boy, now what are we gonna do? Okay, if they need a general anesthesia, probably a neurolept, I would say, is the best way to go. Lots of droperidol, ketamine for induction, or etomidate for induction, lots of narcotics.
What
That's a
about
check.
muscular dystrophy?
Muscular dystrophy is a myopathy, all right? It's a disease of muscles, but it is not related to malignant hyperthermia. There are a couple of, good question, but there are a couple of other diseases that aren't exactly malignant hyperthermia, but we treat as such. There's something called a core myopathy. There's a Denborough syndrome. These are very rare diseases of muscle. If we get a patient with that, though, we usually like to treat it as if it's a malignant hyperthermia. Good questions. Good questions. All right, here it is. We're coming up on Memorial Day now. Saturday night, I'm on call as usual. We're in room 4, and a guy wrapped himself around a tree with a motorcycle. He's got an open tib-fib fracture. Dr. Mangio's in. I go see the patient. He's 40-year-old, he's hypertensive, he's a smoker. He had a blood alcohol of 0.25, and he's feeling no pain, his bone's sticking out, okay? So we go to the office, said, well, we need to get this guy asleep. Otherwise, no medical problems, no history. I get him to sleep, and I use propofol, I use rocuronium, I do a rapid sequence induction, because who knows if he's got a full stomach or not. I get the tube in, I do this, the dials, do this up here, get the stuff, and now I'm fat, dumb, and happy. I'm sitting down, my feet are on the anesthesia machine, got my crossword puzzle. No, that's not what we do. But let me go ahead. And the doctor starts, okay? And looking, and my CO2 starts rising. Is that a problem? No, it happens all the time. Here's the thing though about malignant hyperthermia. It can be insidious in onset. That's a good word, isn't it? Insidious? I don't know what it means, but it sounds good. So it's insidious in onset, and I see the end tidal going up a little bit. I figure, I'm just not ventilating them enough. Because if you hypoventilate, you got more retention of carbon dioxide, and you see the CO2 start to rise. So what do? Increase the tidal volume, increase the respiratory rate. Looks good. Put my feet back on the machine, and life's good. You know, CO2 climbs a little more. Maybe I got the settings wrong. Yes, and this. CO2 keeps rising. And now I see that soda lime canister. Remember it's white granules? Oh, I didn't tell you something. It's always something I forgot to tell you. When it wears out, you know, all good things wear out after a while, even soda lime. The granules go from white to blue. Purple. I'm a little colorblind. The granules turn from white to purple means it's using up the carbon dioxide, which means it's trying to scrub things really hard, and it's turning. And I feel the soda lime canister, and it's feeling warm. So what do I do then? I scratch my head. CO2 is not, normal end-tidal CO2 is like between 35 and 45. All right? Now it's up to 55. And now I'm looking really carefully. I got the tidal volume way up. I got my respiratory rate way up. Still climbing. Now I see some PVCs. All right? I look at my thermometer, you know, my temperature gauge. What's it going to tell me? We're like 10 minutes into the case now. What's it going to tell me? Maybe, but maybe not. That's something else I didn't tell you. I didn't tell you a lot of stuff. But some of the things I'm going to tell you is that the temperature goes up, but it could be a late finding. All right? First thing I'm going to see is that. So I'm saying, I'm not sure what's going on, and now I notice, see this muscle? What's this called? Bueller? Masseter muscle, right. Masseter. Is that, tell me, in terms of strength of the body, is it one of the weakest muscles, a medium muscle, or one of the strongest muscles in the body? Who's got an answer? It's one of the strongest muscles in the body. It starts clenching. I say, now, I don't know what the hell's going on. So one of the smart nurses who went to my lecture says, Dr. Mandel, you talked about this a while ago. Could it be what? MH stands for? And I go, son of a, it might be. So we got the index of suspicion. So what's that smart nurse going to do now? She's going to say, Dr. Mandel, would you please, because all the nurses are very polite. They go, Dr. Mandel, I know I shouldn't say this, but would you consider perhaps, maybe, it's malignant hyperthermia? I go, don't be so brash. No, I wouldn't say that, right? I'd say, you're absolutely right. What is the downside to saying, let's think it's malignant hyperthermia and get into action? What's the downside of that? You're going to irritate the surgeon. That's the only downside. The surgeon is working away, and I say, Doc, I think we might have malignant hyperthermia. We need to initiate the malignant hyperthermia protocol. And we say it, what? With authority. All right? And the surgeon goes, come on, Mandel, you're such a crybaby. You're always trying to get me to hurry up and finish a case. You're a pain in the butt. I said, yes, I'm all of those things, but we got to take care of our patient. So the first thing the nurse is going to do is what? She's going to tell me what to do, which we love to hear. So what am I going to do? I'm going to turn. And so while I'm doing that, what's the nurse going to do next? Get the MH card. So who's my nurse today? All raise your hand. Who's my nurse?
Nobody wants to go in there. Look at that.
I want 3 of you to go and retrieve the MH cart. You all know where it is?
Yeah.
Would you please bring it in? 2 or 3 of you, please bring in the cart now, because we're going to initiate this. While they get in the cart, what am I going to do? First, I'm going to I'm gonna find a way to change my drawers, because this is a real emergency, and I can't do it now, because I'm stuck in the operating room. So what do?
Get the orange thing.
Shut off the gases. I'm gonna shut off the gases, and I'm gonna get rid of those vaporizers. I'm gonna turn them off. I'm gonna put a piece of tape around, because I don't wanna inadvertently do a reflexive thing and turn them on, because that's what we do, right? We start a case, I mean, we've been doing it for years. Yeah, and now what I'm gonna do is, on the MH card is one of these things, and the nurse is gonna toss it to me and say, read the directions and do it. You know how simple it is? Turn off the anesthesia vaporizer. Increase fresh gas flow to 10 liters a minute. That's easy. You turn up the knob and place these on the inspired and expired ports of the anesthesia machine. Okay? It's that easy. So now we've got the cart, and now I'm starting to get worried. I haven't done this in a while. All right? We've got the cart. I hope you all know where it is downstairs. And the question is there a cart upstairs?
Yes.
And you all know where it is?
Yes.
So the next thing you do is what?
Break it open.
Yeah, you open it. We're gonna open it, all right? Because I want you all to see what's in it. Oh, gee, I did do it right. I can't open it. What are we gonna do now?
I got scissors.
Somebody open the damn cart for me, because I'm terrible. Look. Oh, look, I did it, okay? Now, all right, Diana, come on over, help me, please.
Let's get some new people.
New people.
New
people.
folks. No offense.
Yeah, new people. All right, Eric, okay. Here you go. Yeah, so you're with me, and I'm saying, now I'm really nervous, because I'm starting to see some arrhythmias. Okay? And we've got the MH cart in the room, and what's one of the first, now, we got this, we got Anthony here, and we got Diana here, and I say, okay, guys, what do I do next?
Do we have some lights on?
And go right to the top of this thing. Somebody's gonna get on and call this number. There's a malignant hyperthermia hotline. And you call them, there's someone manning or womaning this 24/7. And you get on, and the nurse is gonna say, we may have a malignant hyperthermia emergency. And you know what's great about that? What do you think's so cool about that? They'll tell you everything we need to do. You don't even hardly have to think anymore. So we're in a moment of crisis, and there's some smart MH person on the other end of that line, gonna tell us everything to do, all right? So, they're gonna say, have you turned off the machine? Take it, yep. What's going on? CO2's still going up. We got some arrhythmias. And now the temperature's going up. It can go up as much as 1 degree every few minutes now. Time is of the essence. The sooner you recognize it and start treating it, the sooner you can get a good result. All right? So at this point, the nurse is going to say, we need help, right? There's a bunch of things that need to go on. All right, what's one of the first things you can do to help the patient? The temperature's rising. Where are you going to get the ice? Wherever you can. You got to know where to get the ice.
PACU or the kitchen.
And I would also add, I call a nursing supervisor at this point. Say, we have an MH crisis. We're going to need some, because here it is, Saturday night, Memorial Day, and the folks that aren't here are probably either inebriated, they can't hear, or they're dead asleep. So we need the people, because things always happen on that Saturday night on the holiday weekend, okay?
Tell me about it.
No, right? Am I wrong?
No.
We need, remember, what are we gonna see in malignant hyperthermia now? The cells lysing, we're gonna see an increase in enzymes, we're gonna see myoglobin, so we need a lab drawer, so the laboratory needs to be called. And in the meantime, it's the first thing we need to do, start the dantrium. So folks, come on up, we got syringes here. Kelly, I want 2 people to take a dantrium bottle, and how much do we give? Enough. Who cares? They're going to tell us it's 2.5 milligrams per kilogram. Who's going to remember that? Who cares? So some of you, I want you to start drawing up this.
So if this patient doesn't have a Foley, does he need a Foley?
We're going to get to that. Let's start with the dantrium. Very good. These are all used up. I want you to see how easy or difficult it is. It's going to tell you what to do on here. You know what? I don't remember. It'll tell you on the bottle. Look what the bottle says. It says for treatment And you can sign, use within 6 hours, and they're gonna tell you, I think it's like 20 cc's or 50 cc's. All right, come on up, guys, don't be shy, because the rest of you, I want you to do the Ryanadex. I want one of you to read, come on up, read the instructions, because I'm gonna say, I want to start giving the entry, and I don't have time to tell you how to reconstitute it. Now, has somebody gone to get ice? Where's the ice? Someone go get some ice, because the patient is warming up. So now we're in action, okay? We got a couple things going on.
You can't use a 5, you need a 60.
So you gotta be able to, are there syringes in here?
Not a 60 because we have the Ryanadex
Okay,
in here.
so let's, somebody
You
go,
need a 60.
let's get 160, you know what? Want some of you
Well,
folks to see
he
what it's
wants
like.
people to feel how
This is
hard
the
it is to
bid.
reconstitute.
You guys know how much to draw up? Preparation, look at that, 60 mils of sterile water.
Yeah, it only needs 5
No,
sterile
do we
water.
have
That's
sterile
why I
water in
just
here?
grabbed that one.
So that's a good, do we have sterile
Yeah,
water in
we
here?
do, but it's only for the Ryanadex, it's not for, you know.
Very good.
That's why we don't have
All
any
right,
60s in here.
so, can anybody get me, I'm gonna get a 60 cc syringe, one of you are gonna draw it up, and the rest of you are gonna see how difficult it is to draw.